voice, Bentley P. Colcock of the Leahy Clinic Foundation and the Boston University School of Medicine.
The complications of diverticulitis can present some of the most difficult problems in abdominal surgery. And with the increasing age of our population, I believe that you and I are going to see more of these patients and have to deal with more of them. Diverticulitis, as you well know, can manifest itself in so many different ways and give rise to so many bizarre complications that it presents a challenge to any surgeon. And I might add that probably no condition in the abdomen in which the life and future health of the patient is dependent more upon the good judgment and the skill of the operating surgeon. And therefore, I'm very pleased to have three distinguished surgeons on this panel, each an authority on diverticulitis, and each a representative of a distinguished medical institution.
The three surgeons joining Dr. Colcock in this panel discussion of the modern surgical treatment of diverticulitis include John J. Byrne of Boston University School of Medicine, Gordon A. Donaldson of Harvard Medical School, and John L. Madden of New York Medical College. During this hour of Audio Digest Surgery, Volume 17, Number 3, the week of February 11th, 1970, these surgeons will compare surgical approaches to the patient with multiple diverticula, the patient with multiple diverticula and bleeding, and the patient with recurrent or persistent diverticulitis, then offer some practical pointers in therapeutic techniques, and lastly, point out some fundamental principles in the surgical treatment of diverticulitis. And to begin, here once again, our panel moderator, Bentley P. Colcock.
We're going to start out with a question that bothers some people. Is there any indication for surgery in straight diverticulosis? For instance, let me start out with Dr. Byrne. Jack, would you advise surgery for a patient who comes to see you because of mild abdominal distress associated with perhaps some constipation and whose periamenoma study is negative except for the presence of many diverticula and some irritability of the sigmoid colon?
No, I personally wouldn't. I think the surgery of diverticula can be a very complicated one, and we all know there may be problems with anastomoses and so forth, so it's not just like an appendectomy. And I'm a firm believer that surgery should only be held in abeyance for the people who the operation is mandatory, such as chronicity or some of the other complications of diverticulitis.
Dr. Madden, John, would you agree?
Yes, I'd agree. I think otherwise you'd be doing too many unnecessary operations.
Dr. Donaldson. Butch?
I'm afraid we can't raise any argument here. I certainly am in agreement with this. I think this situation is comparable to duodenal ulcer disease, in which we've discovered a duodenal ulcer, and we certainly don't want to operate on them immediately.
That's right, and so would I. But we all realize that this is a very treacherous disease, and somebody who can be walking around and going about his business all of a sudden comes in to see you because he's passing gas from his urethra. And you know he's in a real serious situation, and he's got a colovesical fistula and doesn't even realize he ever had diverticulitis. So what alerts you to the fact that a patient whom you happen to know by accident had diverticula but has no trouble from them, what alerts you to the fact that he may be getting into some difficulty and you better consider whether or not he ought to be operated upon?
I gather you're asking the complications of
Yes,
disease.
but I'd like to know just what symptoms in the average patient would alert you to the fact that this is no longer just diverticulosis.
Well, I would feel that the development of irregularity in bowel habits, some local tenderness, increased pain, in a patient who's been on a good medical regime would certainly cause me to feel that surgery might be indicated.
John, would you have anything that you'd like to pass along that tells you that this patient has now become someone that may get into trouble?
Well, recurrent attacks of abdominal pain which are not relieved under a conservative management. Symptoms of obstruction would be another indication that I'd be concerned about. Also, if they have pain on passage of urine, one thinks there may be some impending communication between the bladder and the colon, and I think those would be the main indication, without the frank indications of perforation and hemorrhage.
Jack, I'm going to ask you the $64 question. This patient has had a real attack of diverticulitis. He had pain, he had a mass, and he had leukocytosis. It's subsided, however, by the time you get him in the hospital or the day or two later. Are you going to operate on him or not?
Well, I'd be very suspicious of a mass subsiding that rapidly. However, I suppose it could occur. I think what I would probably do with this patient would do a study, do a sigmoidoscopy, do a barium enema and try to see what we're dealing with, because this may be a lot of other things. I have an idea, however, that the patient that you described, you would find something organically wrong with the sigmoid. If there wasn't, there's something else organically wrong with the patient, because I think all left lower quadrant pain is not diverticulitis, always. If you have a severe inflammatory process in the left lower quadrant, I don't rest with the fact that it's diverticulitis and I'm going to think of treating it conservatively or not. I think it's just like an inflammatory process in the right lower quadrant. You've got to be very suspicious that you're dealing with a severe thing. We've all had revivalus of the small intestine and women ovarian diseases and so forth, which bring up a host of differential problems. So I would think that the patient you were describing, I probably would have explored as an inflammatory process to find out exactly what it was and go on from there.
Yes. Well, I think that I would agree with what you have said, but I'm frequently asked about one attack. Well, I think there again, as probably you've gathered from what Dr. Byrne has said, how bad was the attack? Did he have a real mass? Is it going down slowly, or is it just a tender sigmoid, a lot of spasm in it perhaps? Maybe he didn't have but 10,000 count and no fever. Maybe it's just irritable colon and perhaps a rather spastic, irritable sigmoid. But if you've got a real mass, and if it will take more than a few days, Jack, but you may not see him for the first few days. And after a while in the hospital, it's not any worse. He's able to take a little nourishment and it's subsided. Then I think that's a problem, because I think that if he's 55 years of age or 60 years of age, and he really had what you think was a small perforation or a real inflammatory mass involving a sigmoid, he has diverticula, you've ruled out the other things, which of course Dr. Burns pointed out you must do, then I think that some of these patients ought to be advised to have that out before they have another attack, and perhaps the next attack perforate or with obstruction, and you have to do a transverse colostomy. There's one aspect of this that I'd like to clear up before going on, and that's about the patient, John Madden, who has abdominal distress and constipation, but whose barium enema shows his diverticula are large and numerous all the way from the rectosigmoid to the cecum. Would you have any different feeling about this individual?
No, except he's the one that's more apt to bleed and bleed excessively when they do. But if he has no obstructive manifestations, and this is just a radiographic diagnosis, I'd continue to treat that patient conservatively.
Well, I would agree with that, and we're going to come to bleeding right now. But just keep in mind that this patient who has multiple diverticulae all the way is more apt to develop one of the serious complications of diverticulitis than is the patient who just has a few scattered around his sigmoid. I think he has to be watched a little more carefully. All right, Dr. Donaldson, you have a patient with diverticulosis, the sigmoid, but no symptoms. He suddenly begins to pass bright red blood per rectum. What would you do?
Well, we know this individual does have diverticulosis, and this is his first bleeding episode. I think my philosophy would be somewhat as it is with upper GI bleeding. I would be inclined to hospitalize him and watch him and measure his blood loss and by replacement requirements, and being guided by the extent of his bleeding as to whether he should be explored.
Well, this fellow you're seeing for the first time, Gordon, now.
Right, first time, and unreferred, I certainly would proctoscope this individual. And I think we'd certainly have to put him through a barium enema. If diverticulosis were found, and that's what we're talking about, I think that I would not operate on him immediately if the rate of bleeding did not force me to.
Well, I agree, and I think you certainly have in mind what I would like to emphasize at this point, and that is the middle-aged patient who is passing some blood per rectum has carcinoma of the colon until you prove that he doesn't. All too many patients have been treated for months as having diverticulitis, only to find out that they had carcinoma or both, and then it's kind of late. So that I think this is the important point there. Regardless of what you see on that barium enema, if it doesn't rule out carcinoma, you should proctoscope him, as you say, but how often can you rule out carcinoma of the bowel and distinguish it from diverticulitis by proctoscope? Have you been able to do that too often?
Well, I think it's rather difficult, particularly during a bleeding episode.
You and I have had the same experience, I'm sure. You get up to about 6 inches, and then it gets pretty tender, and you can't ever visualize the part that you're trying to make the diagnosis on. Then you turn to the rentgenologist, and in our experience, only about 75 to 80% of the time can he tell you categorically this is not cancer. Any in the panel disagree with that?
Only difficulty I have is the time of operation. There are times I cannot possibly differentiate between the both with the lesion in my hand.
That's right.
I would only like to add one more thing, if you don't mind,
Jack.
Ben, that you raised the question of diagnosis on this patient. A middle-aged patient with bleeding, and to get a barium enema. At our hospital recently, we've had quite a rash of patients with ischemic colitis that come in almost with the same problem. And they usually have some form of heart disease, and they'll come in and have massive bleeding by the GI tract. A barium enema here, of course, will tell us by the fingerprint sign that we're dealing with this syndrome, because there's a completely different prognosis with a different form of management. But again, I want to emphasize that this is something which is occurring.
That's right. Now, the bleeding that is most confusing, of course, is this chap who bleeds a little bit today and a little bit day after tomorrow and a little bit the day after that. This is the type of bleeding that you can get from a patient with diverticulitis, particularly if he has a polyp, and he has a very good chance of having a polyp, or if he just has hemorrhoids. And so you're on the spot, right, until you prove that he doesn't have carcinoma before you start to think, what am I going to do about his diverticulitis or about his bleeding? But how about the patient who has a severe rectal hemorrhage, John, and he has many diverticula? This is a problem not often, but occasionally, and sometimes it's a difficult problem. How would you manage it?
Well, of course, this is a different story. Usually these are the elderly, poor-risk patients, the arteriosclerotic, the hypertensive, and I think you have one chance at them. And I think we should do the definitive procedure at one operation. However, the immediate treatment would be conservative. Hopefully, the patient would stabilize, and then we could do it as an elective procedure. If the patient did stabilize, I would not let the patient out of the hospital until he was operated upon. I assume that the barium röntgenogram shows diverticula throughout the whole of the colon. When I say you have one chance, I would go in and do a total colectomy on this patient with the iliosigmoidostomy, ilioproctostomy. The reason being is that you can go in on these individuals, as I have, where you find a disease segment and you say, there is the cause of the bleeding. You can remove that disease segment by doing a left hemicolectomy, and yet this patient may have recurrent bleeding in the postoperative period. So therefore, again, to avoid reoperations on these poor risk patients, although it may sound radical in the beginning, I think you have the one chance, and I would remove the whole colon as elective procedure. On the other hand, if the patient is continuing to bleed, then you have no recourse. You have to get the patient as stabilized as possible. And while you're stabilizing the patient, you're preparing for operation. And then I would do an emergency total colectomy. Because to do colostomy and coloscopy, to do a transverse colon colostomy, do segmentation of the bowel, I think this is time-consuming and unrewarding, and we're not treating the patient. We're using diagnostic procedures. We know where the patient is bleeding from, and I think we should go right at the heart of the problem, namely the removal of the whole segment of the colon, regardless of which side may be the source of bleeding, because if you think it's on the left side, it may be on the right. If you think it's on the right, it may be on the left, and you have the one chance.
Does it change it any, John, if your x-ray had shown you, if you happen to have been able to get one, that his diverticulosis is limited to his sigmoid?
Well, yes, generally speaking, one then I would think would settle for a removal of the left side of the colon on a percentage basis. I would say yes. But I'd also like to emphasize the fact that it's not the patient with diverticulitis that bleeds, it's the patient with diverticulosis that bleeds.
That's right. But are you going to bother with cross-clamping at all to see where it's from, if maybe he just has 80% of them in the sigmoid and they're scattered along the colon anywhere, before you embark on this?
Well, that would be only applicable in an emergency situation. In the elective situation where the patient has stopped bleeding, then it wouldn't be of any particular value. But in the acute emergency, if you did segmentate the bowel, then probably it may be of value, but I have never been impressed with it myself.
Dr. Donaldson, do you have any opinion on this?
I certainly do. I wish I could disagree with Dr. Madden, but I cannot. I think that a total colectomy is the operation of choice in these individuals that bleed massively. Almost all the ones I've seen have had diverticula scattered throughout the colon, and although our resident staff not too long ago was able to mobilize the colon, put on rubber short clamps, and identify the bleeding by the distension of a segment of bowel, I must say I think it's an awfully difficult stunt in a fat patient with shortened mesentery to be able to do this with the appendices epiploica and omentum and so forth. And I think that one should not delay. One should operate early with adequate blood replacement and carry out a colectomy and an ilioproctostomy. These people get along very well.
Jack, do you have any opinion on this?
No, my experience is more limited in this field, and I must say that I have always attacked the more obvious disease and have attempted to find which side the bleeding is from. However, Dr. Donaldson and Dr. Madden are certainly quite convincing, and there's no question about it. These people do well post-operatively when they've had a total colectomy, and it saves you all this worry, and we've all had it happen to us of taking out the left side and having them bleed again. So I would tend to think that probably their philosophy is correct. I'm not sure that I still would do it in every case, however.
I think all of these cases, regardless of which complication they have, of course, have to be individualized. And if your patient is 80, it's a little different than if he's 55. And also, if he has great many diverticuli throughout, it's a little different problem than if they're limited to one area and you have a fair chance it is coming from that area. Maybe you'd want to use cross-clamping and colostomy incisions to settle it if you were unwilling to put him through complete colectomy, but it certainly is the most effective way of stopping the bleeding. Now, turning to another complication of diverticulitis, you have a patient, 65, Dr. Donaldson, who has developed constipation, slight rectal bleeding. The proctoscopic examination was negative 6 inches. The barium enema shows many diverticula and with marked narrowing of the bowel at one point. Your endocrinologist gives you a diagnosis of probable diverticulitis, but he cannot rule out carcinoma. Specifically, what are you going to do with this man?
Well, I most certainly wouldn't hesitate to explore this individual. The worry, of course, here is that there is malignancy present, and in addition to that, if malignancy is not present, enough fibrosis is present to produce some obstruction. And regardless of any age or perhaps any risk, I would feel this patient should be explored because of the possibility of malignancy.
I think we would all agree with this. And of course, the catch is what's that bowel like when you explore him? If it's only slightly dilated and there isn't a large abscess present, then I think we would all agree that if we can't rule out carcinoma even at operation, when we see it and have it in our hand, as Dr. Madden said, and that's quite possible, then resection is in order. But supposing this patient has gone on to a significant degree of obstruction, Dr. Madden, before you see him and before you get him in, and you haven't ruled out carcinoma, but your proximal descending colon is the size of your arm, then how are you going to handle it?
I would say is that I'd operate on this patient, but I'd do a preliminary decompressive transverse colon colostomy. There's, of course, supposedly some advantages to make your colostomy just proximal to the site of the lesion so that you'll convert it into a 2-stage rather than a 3-stage procedure. I think it's more theoretical than real. I've always found it rather messy to try to go in and include the primary lesion with the proximal colostomy to save a patient the so-called third operation of closure of the colostomy. And I prefer to make it a 3-stage procedure of doing a decompressive colostomy, and then I'd wait a week to 10 days and then go in and explore through a left paramedian incision to treat the primary lesion.
Well, I would agree with that. I feel like you do about incorporating any kind of a colostomy, and what I'd like to have is a clean resection with anastomosis. And so I don't particularly like sigmoid colostomy. I think that if you are dealing with perforation and your lesion in the area of the perforation happens to be high enough and you can exteriorize it, that's fine. But if you're dealing with a situation in which you can't rule out carcinoma, I would like to do as you've done, let that proximal bowel decompress, and then you will have to go back a lot sooner than you would like to if it is only diverticulitis, because the inflammatory reaction that I'm presupposing in this patient is not going to be much different in 2 to 3 weeks. And this is sometimes a problem. So what I like to do is then at the end of a week or 10 days or 2 weeks to do another barium enema. Your endocrinologist may still not be able to tell you, but he have a little more feeling, even at that short interval, that this is inclining a little bit more to diverticulitis. And if you repeat it again in another week, I think perhaps you might be able to pick up the patient who really has diverticulitis, in which you would like to wait a number of months and have that completely subside and then do it in a clean, non-infected field. I wonder if the panel would agree with me here, and that is, if you are dealing with an inflammatory process and the bowel proximally is indurated or edematous all the way up to the splenic flexure, to attempt a resection on that patient without allowing that to subside, I think, is dangerous. And I think it's probably been more responsible for a leak at the suture line postoperatively than any other factor. But let's take up this patient who has recurrent or persistent diverticulitis. You've made a diagnosis, but he continues to have abdominal distress, and his constipation is no better. A barium enema 6 months ago revealed many diverticula and some spasm in the sigmoid, and a barium enema today shows more spasm, but no actual dilatation of the proximal colon. Would you advise him to be operated on, Dr. Byrne?
Yes, I think so.
Dr. Madden?
Yes, I would. We have often been taught for too long a period of time that the surgery of diverticulitis is the surgery of its complications. Then if we follow that rule, we exclude prophylactic surgery, which I think will avoid the complication. And I think this is one patient where you can really do prophylactic surgery and avoid the operation for complications.
Gordon, would you agree?
Yes, I think so. In connection with what Dr. Madden just said, I think that the general thought here is that we are moving into operating on diverticulitis as a primary procedure rather than waiting for the complications of diverticulitis, such as we did in the early 1940s.
Yes, I agree.
I think that's very real, too, because I've just completed looking over the 94 cases we've had at our hospital at the Boston City, where we get, of course, the pretty desperate cases. But our mortality rate for chronic disease alone is about 5%. Our mortality rate for operating on perforated disease is something like 25%. Our mortality rate for operating on them when they're obviously obstructed is in the neighborhood of 20 or 25%. So there's a tremendous difference in mortality rate.
Yes, John.
This is very interesting because, you know, we've been taught for years that in cases of acute cholecystitis, the pathologic process doesn't parallel the clinical findings. And I think this is very applicable to patients with diverticulitis. We recently had a patient with the exact symptoms that you portrayed and very little to go on varimentum, some spasm. I didn't know whether I should or should not, so finally I did operate upon this patient, and she had multiple intramural abscesses in this segment of colon. So the pathologic process was entirely different from the clinical manifestations present, just like we have in gallbladder disease.
I would agree. This is the kind of a patient in which you can safely make an attack on the high morbidity that has been associated with the surgical treatment of diverticulitis in the past, because this patient's bowel is not dilated. You can sew it, and it'll hold if you do it carefully. He doesn't have a large abscess. You ought to be able to, with a good alert system and a suction apparatus, not to have any contamination, even if you uncover a small abscess in the mesentery. And he has recurrent disease, and I think the handwriting is on the wall that he's going to go on to a perforation or obstruction if he isn't done. And this, I think, is the time to do it, because I believe it can be done with a mortality rate of only 1 or 2% at this stage. But now, you have a patient, 67-year-old man who's moderately obese, and last night he developed a sudden severe pain in his left lower quadrant. He has fever, and on examination he has a grapefruit-sized mass in his left lower quadrant. What are you going to do about this patient, Dr. Byrne?
Well, I think this patient deserves a surgery. I would probably explore the left lower quadrant, and I assume that something's been happening here a longer period of time than you think to have a mass develop so suddenly. He's probably developing an abscess, which I think desperately needs drainage. At the same time, I personally would do a transverse colostomy to back this up. Now, there's always a possibility that when you explored the left lower quadrant, you might find a free perforation and no abscess. In that case, I think you might plan a different course of action depending on your philosophy, either a local excision as a la Miculus procedure or an excision alone, because interesting enough, in our figures at the city hospital, our mortality rate for the perforation is no higher than for operating on the patient with the chronic disease. Our mortality rate from disease of the inflammatory nature is only when we're operating on patients with definite abscesses. These are the really serious sick patients, and I think today with chemotherapy, if it's a perforation, free perforation, you can either make a decision to resect it with or without your backing up of your transverse colostomy, or you might do a Miculus procedure. If it was an abscess, however, I think it's mandatory that this abscess be drained as quickly as possible and that you back this up with a transverse colostomy.
Dr. Madden, you've been quoted as doing primary resections on this kind of patient. Would you clarify that and your feeling in this matter?
I treat this patient conservatively, and I'd follow him. Application of local heat, systemic antibiotics, and then sulfacetamide, and observe him. Because my own experience has been interesting that a great majority of these will subside in a period of 36 to 48 hours. We often spoke of these as abscesses, but they resolve too quickly to be an abscess. In 48 hours, there's no mass that you can feel. And therefore, there must be pericolonic edema rather than accumulation of pus. We have two indications to operate on these individuals when we treat them conservatively. If they have shown increasing signs of systemic toxicity over the next 1 or 2 days, or progressively increasing size of the abdominal mass, or increasing pain, then we operate upon them. When we do operate upon them, we drain the abscess, and we do a primary resection anastomosis, going well above the area. Usually it's locally inflammatory. You've got good bowel above and good bowel below. We will not do a complementary transverse colon colostomy only if we immobilize the bowel from the hollow of the sacrum. Because in review of our cases of fistula formation, we found we had a 28% incidence of fistula formation, and we found that the fistulas only occurred in those individuals in which the distal sigmoid and proximal rectum were mobilized from the hollow of the sacrum, and therefore on the basis of vascularity to the lower anastomotic segment. But I would drain the abscess and do a resection, because although this is opposed to the general accepted opinion, we can only go on figures.
Gordon?
I think we're moving into a controversial area now, Ben. I think that I'd have to individualize this patient, and I don't mean to hedge in my discussion, but I think if this were an acute mass that was being well controlled by the patient's reactions, I would be inclined to watch him with the thought that in a matter of a short time, maybe a matter of a few weeks, I'd be able to go in and do a primary resection and save this patient a 3-stage operation. But if you were not controlling it, as evidenced by his fever and white count and so forth, spreading in tenderness, I think that I would be inclined to provide a transverse colostomy and probably drain the local sepsis. If there were frank pus, most certainly drain sepsis. If cellulitis, I would try to avoid a drain. We have tried to avoid draining some of these in a selective way because some of them turn out to be perforated carcinomas. And so many times our carcinoma operation has failed because of recurrent disease in the drainage tract, in the abdominal wall itself, where there is no resistance to cancer. So we are trying to avoid establishing drainage if we feel it's safe. There's a good bit of decompression that's accomplished by a simple transverse colostomy.
I think this is a very important area because this is where we're apt to leave some of you perhaps confused. And yet maybe you would find that all 4 of us would decide on the same thing if we had the patient right in front of us. I have a strong feeling that we ought to ask ourselves, as I ask our residents to ask themselves, and that is, can I cure this patient by a primary resection with a mortality rate of only 1 or 2%? And if I say no to that, I would do what Dr. Burns suggests, a transverse colostomy, because I believe that if we use our good judgment, we can keep the mortality rate for all of these patients down to a neighborhood of 1 or 2%. We do, at the lay clinic, 60% of our procedures by a primary resection. And our mortality rate for some 300 cases that I reviewed representing a 20-year experience at the clinic was 2.5%. That's reasonable. But when you examine those 7 deaths, there were some who, I think, by choice of a little different procedure, might have survived. And when we take the 60 patients who had a 3-stage resection, who represented the most serious risks of the entire group, the oldest, the patients who were sickest, there was no mortality rate.
Excuse me, gentlemen, just one moment to say that this, doctor, is the end of this side of your reel. Side B, the continuation of this program on the modern surgical treatment of diverticulitis, may be heard by reversing the 2 reels or cassette cartridge on your tape recorder. Continuing a program on the modern surgical treatment of diverticulitis, this is Side B, Audio Digest Surgery, Volume 17, Number 3. As we rejoin the panel, moderator Bentley P. Colcock turns to another consideration in the patient with recurrent or persistent diverticulitis.
I think it's important to find out where Dr. Madden, for instance, would use a primary resection in a patient, as I've already said, who has a large abscess and who's 67 years of age and so forth. John?
Yes, you mentioned a very important point. Now, of course, a lot of this is based on a priori reasoning. We say if we do this, we do a transverse colon colostomy, the patient will do well, do better. But then if the patient should die, we say, well, if we did more, we'd be tantamount to the death of the patient, and that he couldn't stand more than the transverse colon colostomy. But is it true? See, this is just theoretical reasoning, and I think we should have a comparative study of what we see in actual fact. Now, there's 2 axioms in surgery that we often hear. One is that when you have a hole in the bowel, you either close the leak or you remove the focus. Now, you cannot close the leak in patients with carcinoma because of the disease, nor in patients with diverticulitis because of the inflammation surrounding it. The other axiom is, when pus runs, so does the surgeon. Now, if we just do a transverse colon colostomy on the patient with the perforation size, what happens to the bowel filled with feces between the site of the perforation and the site you do your transverse colon colostomy? It has to empty through the particular sizable perforation. And that's why many of these people have a very toxic course after their preliminary 1st-stage procedure, whether you just do a proximal colostomy and local drainage. And this is why we have gone into removing the focus, since we can't close a leak. So we drain the abscess, get that pus out of the way, maybe 300, 400 cc of pus. And then after we do that, toilet up the area and do our resection. And if it is end-to-end anastomosis without mobilization of the distal segment, these people do quite well. And this is supported by the fact of our own series. Now, this is in the same institution, and we came upon this accidentally in 1954 when we went in on a patient and found out she had a huge carcinoma with a large abscess. We drained the abscess. We knew the patient had a carcinoma. Should we let this patient go as such and then go back at a second time? Well, I think that would complicate the procedure. We went in and did a real cancer procedure. We did a left hemicolectomy with an aortocaval node dissection and end-to-end anastomosis. And this patient had an uneventful convalescence. Now, we compared our series of 25 patients in which we had done primary resections. These are acute emergencies for abscess and diffusion peritonitis, and we find we have an 8% mortality rate with a primary resection. We thought we'd compare that with collected series in the literature. We have comparable ratio with other surgeons who have done this. Then we compared our own series of 20 patients in which we did the routine stage procedure up to 1954. This is after the first stage only. This doesn't include the resection or the closure of the colostomy. And we have in our own series a 5-fold increase in our mortality rate. And there's a comparable increase in the ratio in collective series in which the stage procedures was done. I think the most impressive one was one by Brown and Toomey of the Western Infirmary in Glasgow, and they reported over 265 cases of diverticular disease, and they broke it down to 53 patients with perforated lesions. And they have a 43% mortality with transverse colon colostomy alone when they use this particular method of treatment. Now, these are consecutive series of cases, so I think it is mandatory that you remove cancer when you have a perforated lesion. I really do, if you're going to get the one chance of this patient. And since you cannot possibly differentiate 100% between benignocy and malignancy, then I would assume the only way to get the final answer is remove all perforated lesions, so you include all carcinomas.
Well, John, the only reason I would differ with you is, first place, the number of patients that you can't distinguish are few. I'm talking about the patients that we have established a diagnosis on. So we'll leave those out. And of course, if you've got carcinoma, you're going to do a resection. That shouldn't be a part of our problem here. But if you've got a patient and he's elderly and he's obese and he's got a large abscess there, in my experience, he doesn't have an open hole like a gunshot wound. He isn't pouring out into his peritoneal cavity once in a while, but rarely. This is usually well walled off. And some pretty good surgeons in years gone by used to go in on this situation, and when they did a primary resection, the mortality rate was pretty high. I don't think it was all due to their inexpertness. I think here we've got a lesion that we know will subside. It isn't a free hole now, it's walled off. And we've got a poor risk patient in some respects. So I think here, at least, is where I would differ from you perhaps, and because I believe that we ought to be shooting not for an 8% mortality rate, we ought to be shooting for a 1 or 2% mortality rate, provided we pick the right procedure for the particular patient. Bush, do you want to add anything to that?
I did want to say that statistically, and statistics are dangerous, but statistically at the general, we have a lower mortality operation-wise, a 3-stage operation, a lower mortality than we do with our primary resection. It's in the neighborhood of, I think, something like 2.4 as against 4% mortality for primary resections. And of course, those who undergo a 3-stage operation are generally sicker individuals. There are comparable numbers of patients in each series, and I think this is one of the things that has influenced us to be perhaps a little more conservative than Dr. Madden has. I also think that we ought to differentiate the perforated carcinomas from the perforated diverticulitis if we can, because in perforated carcinoma, the bowel proximally and distally so often is quite normal, and I think that one can get normal bowel mobilized and do a careful anastomosis, whereas with diverticulitis it's less apt to be so.
Would you agree with that, John?
No, I wouldn't. I just can't make the differentiation at times. So it's obvious many times you're dealing with a carcinoma. It's very obvious you're dealing with diverticulitis. But there are occasions where it just seems to me an impossibility. We had one just like that. We drained, and about 5 weeks later, we found a rather peculiar appearance in the wound itself. We took a biopsy, and this was carcinoma. And the rapidity of spread of the carcinoma once it perforates is very well known. But I'd like to ask you, Ben, and Gordon, Jack, you are called in to see a patient, and the diagnosis is made of acute surgical abdomen. You don't know what you have, whether it's a perforated ulcer, acute appendicitis, acute diverticulitis. So you make a incision, lo and behold, you find a diffusion peritonitis due to free perforation of a sigmoid colon. Are you going to do a 3-stage procedure there, or what are you going to do?
No, I'll answer that. Of course not. But in our experience, perhaps we see a little different variety than you do. This is not 1 out of 10 in our experience in patients with diverticulitis. And I agree also, if you can't rule out carcinoma, you've got to do a resection. I agree also that if you have a free hole, except that if I have a bad risk patient and I have diffuse peritonitis and I have reason to think it's still pouring out bowel material, then if it's high enough, I would probably exteriorize it, the old Miculus type of resection, and if it's not high enough, I might do, for this rare instance, a sigmoid colostomy and turn in the lower end. I believe you've got to close an open hole as quickly as you can. But I also, at least in our experience, this is an unusual situation in diverticulitis. Gordon, you had something?
Yes, I did want to correct one point, and that is that the carcinoma, I had felt ought to be distinguished from diverticulitis, and I certainly wholeheartedly agree that a perforated carcinoma should be primarily resected. In the group of our own experience, our mortality from resection of perforated carcinomas of the colon was, I think, 5%. Whereas when they were treated by a three-stage maneuver, the mortality was over double that. So that I would go along with Dr. Madden, certainly, that in the case of carcinoma, that it's much preferred to do a resection.
If you can't rule it out. But then again, this is the unusual case. Jack, do you have anything to add to this?
Yeah. I know it's Dr. Madden's series, so he's talking about perforation and comparing it to perforated carcinomas, which we in our institution believe similarly that a perforated carcinoma should be resected.
Yes.
Now, this was surprising to me when I reviewed our results, that the only patients who died from the inflammatory disease here were the patients who had perforations. Yet, if it was peritonitis, it was a hole with free peritonitis and no obvious abscess formation. I mean this great phlegmonous mass, this thing is almost like a carbuncle in the patient, which I think needs drainage. I think we're talking about different things, because even in our series with 11 patients with the free perforation and peritonitis, there were no deaths in a very sick population. On the other hand, when we had abscesses, we had more deaths. We had less if we did a transverse colostomy and an I&D. There are only 5 in that series. I'm not sure today that they should probably have been drained even more. It could very well be that maybe if we had resected this inflammatory tissue, we'd have a lower mortality rate. Our worst rate was, however, when we just did a transverse colostomy, and that's all. Those patients did quite poorly. So I do think it's important to realize whether we're talking about a free perforation like peritonitis, which today, with the chemotherapy and so forth, we can handle moderately well, compared to this phlegmon, this abscess, which is present with a thick wall of 4 and 5 inches, which will drain for weeks and weeks and weeks. I think Dr. Turnbull from Cleveland is having some very important information on this coming out, that these patients need very prolonged drainage, even without a resection. And he will leave his drains in for 21 to 24 days routinely without taking them out. I think this is going to be a very important step forward as he reports his results. But
well, as you can see, we have to individualize these patients. As I said before, I suspect that if we were faced with the same patient right in front of us, we might be closer together than we think. And yet, I think we can say this, that there is a place for a staged operative approach in this disease. You can reduce morbidity in selected cases, and I've tried to point out the kind of cases in which you can do it and do it safely. But it's no kindness to a patient to take an undue risk on his life in order to keep him from having another operative procedure. Now, a few questions on technique. We sort of agreed, I think, if we did a proximal colostomy, we did it in the transverse colon. But what kind of a colostomy do you construct? I have one particular point in mind, Dr. Donaldson.
I would make a transverse incision in the right upper quadrant and feel the gallbladder, make sure there are no stones palpable, and then establish a colostomy then.
You divide the bowel?
And divide the bowel completely.
Yeah. I think this is important. If you're going to do a diversion colostomy, make sure it does divert. Otherwise, it's not going to do what you asked it to do. And very often, I'll be asked to see a patient because of the persistence of an inflammatory process in the left lower quadrant several months after, due to the fact that fecal material was continually spilling over from a colostomy that did not divert it. When it does divert it, the only other factor that I've seen keep inflammatory process in the left lower quadrant going was a small bowel fistula, because it bypassed the colostomy.
I'd like to disagree with that, if I may. We do a loop colostomy continuity and find out you don't have to do the Wangenstein modification of that at all. They retract very nicely. The bowel doesn't function for 3 or 4 days after you do this. You'd open it at the time of the operation. It's worked out very satisfactorily.
Yeah, well, I would agree, Don, if you're trying to decompress the bowel, if your problem was obstruction, it'll let the gas out all right. But if you had a perforation down there with a long inflammatory process involving the whole left colon, I think if you want it to subside and subside in a reasonable length of time, I would like to keep all fecal material out of it.
Well, we resect that segment.
Yes, yeah. I can see you don't come to that problem. But let me point out, while making due allowance for the different kind of case that Dr. Madden and I see, I'm shooting, and my residents are taught to shoot, for a 1 to 2% mortality, provided they pick the proper operative procedure. Come all. Now, he may see more patients with perforation than I do, and that might make it quite different. Do you ever close the colostomy at the time of resection? I'm asked this question a good many times. Gordon?
Well, I have done it, but I'm not enthusiastic about it. I think it's better not to.
Well, I think that we have to keep in mind that if we close the colostomy, the only thing we do is shorten it from 3 to 2, and we leave out the least serious of the operative procedures. And the minute we close that colostomy, we have thrown away a great advantage. If there's any question about the integrity of your anastomosis, I feel it's a little foolish to close the colostomy at the same time. Any disagreement with the rest of the panel? And I mentioned the exteriorization procedure, and I'm frequently asked about that. I think it's fine if your lesion is high enough that you can get it up without tension on the lower loop, but don't try to bring up a inflammatory mass in the lower sigmoid in which the lower loop barely reaches the peritoneum, because it'll retract and you may have real serious consequences. And Dr. Madden has also commented on something else that I'm frequently asked about: a total colectomy with an rectal anastomosis for a patient with diverticulitis. I think I can count the number of times I've done it on the fingers of my 2 hands. It is not often indicated, but I have done it. How about you, Gordon?
Yes.
If you have a great many diverticula throughout the entire colon, I don't know where you can do that anastomosis short of a total colectomy and do it safely. You're going to have to put sutures through diverticula, and you know they're paper thin, and I think that that kind of anastomosis is very likely to leak. Have you ever operated on a patient with a diagnosis of acute appendicitis and found the symptoms due to an indurated inflamed segment of sigmoid colon, Jack?
Yeah, that happens occasionally, and I usually take out the appendix. I will probably drain the area of the inflammation in the sigmoid, and I'll do a transverse colostomy. I assume if a man has this much difficulty, he's on his way to very serious disease and should have resection, essentially.
Any difference, Gordon?
I think I'd be a little more conservative than Jack. My philosophy is a little bit like the individual with a surprise finding of regional enteritis. I'd certainly want to take out the appendix in this diverticulitis patient and probably do nothing more if this is a matter of acute diverticulitis without any evidence of perforation. Treat him conservatively and hopefully allow the interns to carry on.
John, would you do a primary resection here?
We had one. This was before 1954. And we operated upon him for acute appendicitis. The appendix was perfectly normal. He had a collection of pus in the pelvis and simple drainage. I did not remove his appendix. And he subsequently had a resection of his lesion 2 weeks later.
Here's a question. How do you feel about cecostomy for decompression versus a transverse colostomy, Jack? I have some very definite opinions on this.
Well, obviously, the worst thing you can do in diverticulitis is cecostomy, and as I look back over the last 25 years at our hospital, some of the most tragic things that have occurred have been using cecostomies for diverticulitis. It's just something to be condemned. At least I think so. And I think if you need backup for your resection, it should be a good transverse colostomy. I don't really think it makes much difference whether it's a loop colostomy, which I tend to use at our hospital, or whether you're completely divided. I've gone in 6 months later after complete division of the colon and found just as much disease in the left lower quadrant as there was the day we left it. So I'm really not quite sure how much protection these colostomies are anyways from this inflammatory process.
I think this can happen, but I don't think it happens as a rule unless you have a lot of feces going over, unless you have a small bowel component, or unless there's been previous surgery down there. I find that an abscess that occurs as a result of a leak at the suture line will do just what you said over and over again. It will still be inflamed regardless of the proximal colostomy, even though it's diverting, because there's something that we do as surgeons down there that interferes with nature's method of handling a perforation of the sigmoid colon. What specific antibiotics do you use systemically in acute diverticulitis? John, you mentioned treating these patients for a while conservatively to let it subside.
I usually use penicillin terramycin. I don't know how good it does, but that's what we use.
And do you have any hesitancy in doing a barium enema in acute diverticulitis? In subsiding diverticulitis?
Well, I'd wait for a week to 10 days before I do it, then I wouldn't have no hesitancy to do it.
Any comment, Jack or Gordon?
No, while you're on the question of the urinary tract, however, I do think we ought to emphasize, at least I learned something in the last year or so, that quite a few of our patients who die following surgery for diverticulitis don't die necessarily of diverticulitis, but a third of our cases have died of pyelonephritis. And I think this is something else to consider when you're considering conservative management of diverticulitis, and also when you are treating a patient with diverticulitis, to give strict management to the genitourinary tract, because it is quite often severely inflamed and may be the cause of death if it's neglected.
Here's a question. What is your usual routine in care of the transverse colostomy while waiting to do the second stage resection? Irrigating the distal segment or not? Well, no, not usually. I think if you do the transverse colostomy and you divert it, if you've got a large abscess, you drain it at the same time. In our experience, nature will take care of the rest of it, unless, as I say, you're being bypassed by a small bowel fistula or somebody else has tried a primary resection and what you're dealing with is a leak from the anastomosis. Then I have seen these patients go on with no improvement in spite of a diverting colostomy. What is the safety in doing a proctoscopic and barium enema study in the presence of acute inflammatory process, with or without an abscess in the sigmoid colon? Jack?
Well, we've all seen instances of barium in the peritoneal cavity following barium enema for diverticulitis. And I tend to agree with our oncologist, Dr. Shapiro, who does not believe this is any very harmful. Barium is a rather innocuous substance. I think if your oncologist will take care during his examination, if you alert him, I think it's your duty in our problems we have today in communication to let your oncologist know what's going on and tell them that you're worried about diverticulitis so they don't put that can up to the ceiling and then very carefully do the enema. I don't think you're going to cause any difficulty. And I think the times that barium enema does come through are the times when you've actually had the perforation. All you're doing is proving the perforation, and you're probably going to have to go ahead and this is a case you're going to operate on anyway. So really, I'm not too much worried about this problem, providing you alert the oncologist to the fact that you do have such a problem.
I've been asked about the elderly, not a good risk patient who has been treated successfully with the colostomy, and what about leaving that patient with a colostomy? Gordon, you ever done that?
Oh, yes, I think that this is commendable. Of course, again, we have to individualize the patient. One thing I would most certainly not do, and that would be, at the insistence of the family, perhaps close the colostomy without doing something to the area of disease, because Dr. Smithwick and Dr. Hayden, Parker Hayden, in the past have collected our figures at the MGH and found, I think, a recurrence rate of 45% trouble with the diverticular.
I'd like to have each one of the panelists summarize what they consider to be the fundamental principles in the surgical treatment of patients with diverticulitis. And we'll start with you, Jack.
Well, I'm a believer that we should not allow the diverticulitis to reach the stage of complication if we possibly can, and that we should do earlier surgery than we have in the past. And I think the trend and tendency is toward excision of your tissue. And I think as far as the technique of the operation is concerned, one of the most important things in the actual excision of your disease is to be sure that your anastomosis is completely loose. And in practically every case, I think it's mandatory that you take down the splenic flexure so you have these two loops of bowel completely lying alongside each other, so even if one stitch gives way, there's not going to be any tendency as distension occurs or something like that to pull this anastomosis apart, and that it will heal almost in situ. I believe the anastomosis should all be drained locally. I'm changing my mind as about how long, but I do think it's important that it should be, because even if a leak does occur, you then will leak out alongside the drain. You then leave that drain in a while, and nothing too seriously is going to happen.
John?
Well, to use a trite statement, it'd be rigid individualization, and I do believe that we should go more to the prophylactic surgical aspects rather than wait to treat the complications. And as far as primary resection is concerned in the treatment of abscess and perforation, there are three things: good blood supply, good anastomosis, and no tension. And if you have those three at all times, I don't think you have to worry whether you have or have not a local peritonitis. I'd have no objection whatsoever for people to do a resection and a complementary transverse colon colostomy. In other words, make a two-stage procedure here, whether it was interperitoneal or a infraperitoneal anastomosis. I don't think it makes any difference. But the most important thing is to remove that focus, really. And the only way that you can judge it is by you compare your own experience with those people who have had the transverse colon colostomy with or without local drainage, with those who have had resection, whether you want to do or do not a complementary transverse colon colostomy. And here, Jack Byrne just showed a beautiful study that supports my own. He had 18 patients with 5 deaths, or 62% mortality with transverse colon colostomy in his abscesses. That's not good. And here he gets these people who are acutely ill. And the thing I'd like to emphasize, remove the focus. And if you want to, as a routine, go ahead and do a transverse colon colostomy. I have no objection whatsoever.
Would you answer one question for me? Is there a place for staged resection in the treatment of this disease? Because a lot of people feel that you don't believe there is.
In obstruction, yes.
Right. Gordon?
I think things have been covered quite well, Ben. I would emphasize that when we do have a patient with diverticulitis, that we must not turn them over to the internist. If they're to be followed conservatively, I think we ought to keep an eye on them. I think that if we're going to avoid operating on the complications of diverticulitis and perform more primary surgery, I would go along with what Dr. Madden said about the three big principles that are so important here, particularly where the bowel is apt to be edematous, sutures are not well tolerated. It's terribly important to have good blood supply and lack of tension.
Maybe I can summarize what I feel and what I think probably most of our panelists feel. This disease, this condition that we're talking about, I think is a challenge to every one of us. In the first place, it's probably going to increase in frequency with the increasing age of our population. We must never treat a patient for weeks or months with the thought that he has diverticulitis until we have absolutely ruled out carcinoma of the colon. We have been too long putting up with a high morbidity in this disease because we waited for the complications, perforation, obstruction, or a fistula to develop. In fact, this was what we were all taught, or most of us were taught. And we know that patients with recurrent or intermittent, persistent attacks of diverticulitis, when they're not obstructed and there isn't a large abscess or a frozen pelvis, can be resected in one operation with a very low mortality rate. And then let us not forget, too, that if we make a wrong decision or we don't carry out our procedure well, that we can still lose that patient because patients still die from diverticulitis. A few years ago, having been in the position that Dr. Madden mentioned that even when I had it in my hand, I can't tell whether it's carcinoma or diverticulitis, I decided I didn't want to be in that position. The rentgenologist had said it was equivocal. So I'd go over these cases carefully and see if I couldn't tell from the history what would help me. And I came up, having analyzed them with the proverbial fine-tooth comb, only with three factors that were statistically significant. Gross rectal bleeding was more common in patients with cancer than it was in diverticulitis, and severe pain, significant pain, sharp pain, was 3 times as frequent approximately in patients with the inflammatory disease as it was in cancer. And then fortunately, most patients, not the majority by any means, as you well know, the majority of patients with diverticulitis have had symptoms for many months, the majority in our experience for over a year, and fortunately it's less than that with carcinoma. And the fact that we do believe in primary resection, John, in fact that 60% of our patients do have a primary resection. 3-stage resection was done in 20%, or approximately 60 patients, and the others were various modifications that you've heard members of the panel mention, such as perhaps closure of your colostomy at the time of your resection, or doing a complementary colostomy at the time of your resection, then closing it later. And this is our experience. It will be a little different from Dr. Madden's or Dr. Burns and Dr. Donaldson's, but at least it covers a 20-year period. It's not just taken of a small segment of time. It also covers a fair number of patients in that there were close to 300 patients. The overall mortality rate was 2.38%. I feel very strongly from having gone over these deaths, it could have been less. It ought to have been down around 1 or 1.5% at most. Those 60 patients who had a 1-stage resection, who had the severest form of the disease, who were the most obese, the oldest, the poorest risk patients, because they were handled in a carefully planned manner, did get by without any deaths. And I think this is what we ought to shoot for, keeping in mind that the average case, if we get him before he's perforated or become obstructed, we can do him in 1-stage resection. But there is still a place for doing them in stage resections if you don't get him that early. And you'll note that our panel hasn't asked you to do all of these patients, even Dr. Madden hasn't, by a 1-stage resection, and I'm not asking you to do them all by a 3-stage resection, and neither is Dr. Burns or Dr. Donaldson. This calls for judgment, and the closer we can come to using good judgment and good technique, we will be able to keep down the morbidity rate of these patients, and we should, I think, be able to do them with a very reasonable mortality rate. And if we have been able to contribute anything from our experience, that will help you in handling and individualizing the particular patient that you're faced with, then it's been worthwhile, and thank you for coming.
Thank you, gentlemen. Before concluding this issue, here's one brief item of therapeutic note, a clinical quickie. To heal ulcerated areas and to get rid of odors, you might try using dried yogurt flakes or buttermilk, says Roald Grant of the American Cancer Society. Noting the daily use of these agents at a New York cancer hospital, he says the idea behind this therapy is to fight bacteria with bacteria. Most odor-causing bacteria thrive in an alkaline medium. Yogurt and buttermilk produce an acid medium and thereby stop growth of the offensive bacteria. The agents can be used interchangeably, except that yogurt is more expensive and should be reserved for smaller, more inaccessible areas like head and neck ulcerations. An important use is for ulcerating breast cancers. Buttermilk is effective for large decubitus ulcers and also as an irrigant in vaginal douches or colostomy irrigation. And this doctor concludes this edition of Audio Digest Surgery. Your next issue will be a program devoted to day-to-day problems in pediatric surgery: inguinal hernia, undescended testis, branchial cleft anomalies, and pyloric stenosis. Audio Digest Surgery is produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. All rights regarding reuse of this material are reserved.